tonight for our speaker series, we have updates in ovarian cancer. So tonight we will be joined by one of the best, and we are lucky enough to call Dr. Shahin a Unite for Her provider to learn so much about what's been happening from recent annual meetings. We'll be learning a little bit and talking about the future of cancer research, as well as the impact from exercise on health. And then, of course, the use of hormonal therapy. So a lot of different topics to get covered, a lot of information. It's why we like to record these. But again, we will have time at the end for some Q&A and some discussion. So be sure to keep your pen and paper handy. Let me add on my esteemed co-host to join us this evening, Sue Weldon. Thanks so much, Sue.
Good evening, everybody. So glad you joined us. Always happy to join our wonderful Unite for Her community,
Yeah, and we're in for a treat this evening. So a lot of learning, and we still have participants coming in, which is great. So we'll give them another minute.
Terrific. I think everybody knows. Did you do a little of our housekeeping, Erin?
I did not. I just opened up our topic for this evening, but we will like to keep everyone muted. Feel free to use the chat to not only submit questions, but also if you want to share where you're tuning in from. We love to see where our members are viewing from across the country, because we have members in all 50 states. Once we get to the Q&A portion of our session, feel free to raise your hand. Sue and I will be monitoring the chat as Dr. Shahin is sharing information. So we'll be watching all of that moving forward. And if you haven't joined one of our education segments before, let us introduce ourselves. So my name is Erin Pellegrin. I'm our Senior Director of Culinary Nutrition and Education here at Unite for Her.
Yep. And my name is Sue Weldon. I'm the founder and CEO of Unite for Her, and always like to say 21-year survivor. So always happy to join our community and bring these very important topics front and center.
Absolutely. And of course, we could not do that without the help of our truly incredible education sponsors. And so this evening's speaker series is presented by our sponsors, West, Merck, Lilly, Novartis, and Gilead Sciences. We have additional support from our gold sponsors of Pfizer, GSK, and Daiichi Sankyo. And we have additional support from AbbVie, Tercera Therapeutics, and Veristem Oncology. So we are so grateful for their ongoing support. And we've got a lot coming to you throughout the month of September. So stay tuned on our social media and our newsletters coming out, because we've got a lot of topics and discussions to be had. And we are just kicking off with our updates in ovarian cancer tonight.
Yeah, I'm glad the chat is active as well. We do want to let all of you know you drive a lot of our conversations. So please tell us, if there's something that you want us to cover, please let Erin and I know. We are all ears. We do survey our community on topics that they feel are very important or top of mind. Of course, we go to all of the largest conferences. We have incredible advisors that lead those discussions as well. And you can see the support that we're getting enables us to have now. Gosh, Erin, I feel like we're at 48 a year. We have a lot of sessions that we're offering, speaker series, Ask the Experts, virtual hangouts. So please, even tonight, if there's a topic, pop it in the chat. We're always happy to put that on our calendar and try and find a way to schedule it in.
Absolutely. And so with that, I will share a little bit of what you have to look forward to through the month of September. So next week, we've got 3 education segments coming your way. So if you have your calendar handy, grab that pen and paper. So on Wednesday, September 2nd, 5 p.m., we have our virtual hangout, Voices in Oncofertility. So we will be having a panel discussion with patient and providers in the oncofertility space. We'll have Dr. Terry Woodard joining us from MD Anderson in Texas, as well as the founder of Worth the Wait, another advocacy nonprofit that is in the oncofertility world, and as well as a Unite for Her member to share her story as well. So we're really excited to dive into this topic. Again, Wednesday, September 10th, 5 p.m. Eastern time. The next day, we've got 2 segments happening on the 11th. In the afternoon, I will be joined by my colleague Aubrey, and we will be having our Ask the Experts with all about supplements and cancer. So clearing the confusion. And we will be joined by a fellow dietitian who is an expert in the supplement space, Natalie Ledesmy. She's out of San Francisco, has been working in the oncology nutrition realm for well more than a decade, and just a real expert in this space. So we're really excited to answer your common questions about a variety of our most frequently asked supplements in oncology care. And then that evening, we will be having another speaker series at 6 p.m. Eastern Time, all on cardiorespiratory fitness and cancer. And we'll be joined by a physical therapist here locally from Doylestown Hospital, Nikki Gresmer. And she is an expert in cardio care, and she'll be touching on the benefit of working with a cardiac specialist physical therapist and how that can help to minimize the effects some of our regimens have on long-term heart health. So there's also some really exciting research that she wants to share. So I always say, listen, we're always thinking about our heart health right from the beginning. And so even when we're looking at movement, this is a great way to ensure that we are protecting that. And so if you can't join for any of these segments, do not worry. As like tonight, it will all be recorded and available on our UFH Connect video library. I will pop that link in the chat so you can view not only tonight's recording, but all of our past and future segments.
Yeah, and I'm seeing our chat. We do have some comments, which is great on some topics. With that being said, Erin talked about our library. Please also search our library for some of these topics. We may have covered them over the past 4 years. We keep that library very up to date to ensure that everything is relevant and that we have the best, brightest minds there speaking for you, and it all is up to date with the newest regimens for cancer care. So please look there. You can Google and search by topic, which allows you to find many topics. And we even put like the ones that are most searched as a little cue, because sometimes you don't know what to look for, and we put that front and center for you. So that's great. Thank you, Erin.
You're welcome.
Should we tell everybody why we're wearing green tonight?
I guess if you're
Let's see if they
outside
can
of the,
guess.
yeah, I know. We have a lot of those outside of the Pennsylvania area. So maybe you can share for those that are not in our region.
Yeah, well, if you're in the Philadelphia area, the Eagles are playing tonight. Their opening game, and we are all big fans. So
I see Heidi. She's got her shirt on. I love it. I love it.
we got our green on tonight. We were debating putting the jerseys on, but always in that good spirit of our Philadelphia community. Yeah. All right, are we ready, Erin?
Oh, so excited. Absolutely. Let's jump in.
Yeah, it's my honor to give Dr. Mark Shahin a beautiful introduction. He is the Chief Surgical Officer and Board Certified Gynecological Oncologist. He is currently the Associate Director for Clinical Research and Cancer at the Cancer Institute, and Gynecologic Oncology Fellowship Director at Penn State Health Hershey Medical Center location. He is recognized for pioneering his work in clinical research, leading trials on novel therapies such as immunotherapy in recurrent endometrial cancer, and has authored over 50 publications. For more than 25 years, he has held leadership positions, including the Director of Hogany Institute for Gynecologic Oncology, Deputy Director of the Ashplund Cancer Pavilion, and Enterprise Director of the Gynecologic Oncology for Jefferson Health. And we at Unite for Her are most honored to have him because he serves on our board for more than 8 years now and one of our professional medical advisors for over 9 years. So Dr. Shahin, you are the best. Thank you for coming. We appreciate you. And let's take it away.
I don't know who you're describing, but thank you. That's wonderful. I feel bad because I don't have anything green on. So I am an Eagles fan, and as I was telling Erin earlier, some plans at home had to be changed because my wife says, "Nope, we're sitting tonight home. We're not going anywhere. We're watching the Eagles." So thank you for coming to this webinar, and we hope to learn from each other. And wanted to review the topics that Erin and Sue briefly mentioned. I'd like to always just start in, what's new in the space of ovarian cancer from all the national and international meetings that we attend. And, surgery has always played a big role in ovarian cancer. It used to be pretty much the first intervention for patients. And one of the things that's come about um, over the last 10 to 15 years, there was some series of trials that were done initially in Europe, subsequently in China, then again in international space, in exploring whether the surgery should be done right away or should it be done as an interval surgery. A lot of the proud surgeons in the US were critical of that because they really felt like that initial surgery is really important. What we have learned from these trials is that interval surgery is not inferior to the primary surgery, and in some patients, actually is advantageous. Part of this treatment of ovarian cancer is a long-term battle, and you don't want to lose in the first quarter or the second quarter, so to speak. And what happens is we used to run into some patients who were really not suitable candidates for surgery, and we would do a lot, and then they would be sick in the ICU and not recover properly to get their chemotherapy. And so over the last probably 15 years, after these 5 trials, I can really safely come to you and say that even in the best of hands, really complicated initial surgery may not be suitable. And another recent publication was that you also want to have your surgery by people who do this more than 10 times a year in centers that take care of a lot of these kind of it does make a huge difference. So the most recent publication came out of a German group, and this group was very selective. They thought that they were the best surgeons, and if they do the surgery up front, they're going to get better results. Guess what? There was no difference in the individuals who had interval debulking surgery or primary surgery. So even in the best of hands, the interval surgery seems to be a safe approach. And I know many of the folks who are on the call here and this Zoom meeting today, they have had already their surgery. But there are patients that walk into our office every week and need to make that determination and decision about how to go forward. So that's the first thing I wanted to talk about. The second was a number of drugs are beginning to make their way into space of ovarian cancer. Many of you listen to some of your friends and relatives and TV commercials about immunotherapy. The immune checkpoint inhibitors have been really revolutionizing care of our patients in melanoma, in lung cancer, in some of the colorectal cancers, as well as even in endometrial cancer, uterine cancer, which is now, believe it or not, more people die of uterine cancer in the US than they do from ovarian cancer. There has been several trials that have been done, and these are large trials. Finally, the last 2, they really explored it and asked the question properly, meaning that you receive your chemotherapy and then you go on a maintenance treatment with combination of immunotherapy, possibly one of these PARP inhibitors like olaparib, niraparib, rucaparib, and then you may be on also Avastin or bevacizumab, depending on whether your doctor believes that it's appropriate for you or not. And the latest trial came with Keytruda, which is made by Merck, as well as dostarlimab, which is made by GSK. Both of these trials had similar findings. So in the right setting, it improved time to progression of cancer. So on average, the patients got another 7 or 8 months before their cancer reoccurred. However, when these patients were followed all the way to the end, their overall survival did not improve. That was disappointing because what we were hoping for is an intervention that you do up front that really gives you longevity, overall survival. And so we have been going through this and analyzing, is there a subgroup that may benefit from the checkpoint inhibitors? And so far, and again, this is this information was released probably in April or May, and we've been digging and digging into this data. We haven't really identified who that individual is. We think the population that may have homologous recombinant proficient tumor, not HRD, HRP, may be benefiting. Although when you start asking these subgroup questions, sometimes this study doesn't have the power to answer that. So it's been a little bit of a disappointment because we have invested so much effort into these trials. But without these trials, the field never goes forward. So we are digging into that data, trying to figure out who this is appropriate for. But on the other end, when patients develop platinum-resistant drugs, ovarian cancer, Merck has actually recently released the results of a trial, B96, which shows that if you receive weekly Taxol with bevacizumab and add Keytruda to that, or pembrolizumab to that, that there is an overall survival benefit. So what we're learning is that maybe there is not benefit up front, but maybe later when patients have recurrent platinum-resistant ovarian cancer. So that's exciting. I believe those results are going to be presented at the European Society of Medical Oncology in October in Berlin. So I'm looking forward to that. One of the other trials that came about in May and resulted, the drug is still not on the market, but it was a drug called relacorilant. And the patients were receiving nab-paclitaxel. This is Abraxane for some of you who might have received it. It's a drug that's similar to Taxol, but it's shorter infusion, and patients receive this weekly, again, in the same setting, platinum-resistant ovarian cancer. And these individuals, relacorilant has an effect on the steroid metabolism. So patients cannot get steroids, and that's why they chose Abraxane. But when relacorilant was added to the Abraxane and you took it as a tablet pill the day before, the day of chemo, and the day after, so for 3 days, all of a sudden, the overall survival of these patients were improved very significantly. The drug is going through FDA review for approval. I suspect it's going to get an approval sometimes in the fall. And it's a really exciting new way to treat recurrent ovarian cancer. The drug is made by a company called Corcept. The other piece of information that I wanted to share with you is a couple of years ago, we had the really benefit of seeing folate receptor alpha being now a major marker for our ovarian cancer patients. But the drug that we were looking at was called mirvetuximab, or Elahere. Some of you may be familiar with that. And Elahere, when it was studied across the board in ovarian cancer, it didn't work. It didn't show benefit. Now, many of you might have heard the term antibody drug conjugate. To put it simply, it's a Trojan horse. So what happens, there is an antibody that binds to the cancer cell, then this gets internalized, and now we can release the drug, the chemotherapy, directly into the cancer cells. What this does, it allows us to deliver drugs that we could never previously deliver directly into the cancer cells. And Elahere, when it was studied, they noticed that if you have high expression of that folate receptor alpha, all of a sudden the drug shows a survival advantage. And so now for the past over at least a year or more, Elahere has become really part of our armamentarium. for our patients who have high expression of the folate receptor alpha. And that's what's currently available. The next phase is a drug that's being investigated in clinical trial, and it's called RINA-S, RINA-S. The name is too long. I'm not going to review it in it. It's a rinatobart sacitatican, but RINA-S. RINA-S uses the same folic acid receptor, except it doesn't need it to be high. So you can take patients who have lower expression of folate receptor alpha, give them RINA-S, and RINA-S seems to be an active agent both in ovary and also uterine cancer. So this is new information. Some of the new trials now using RINA-S versus standard chemotherapy have just opened up, and we are enrolling patients for that. So if you happen to need treatment and you have a folate receptor alpha that's not high, or maybe you are high and you've already received Elahere, now you are actually a candidate to go on one of these trials. There's a 50-50 chance you may get RINA-S versus standard chemotherapy. Patients are always bothered by that 50-50 chance of getting the drug, but I will tell you, 50 is better than 0. The drug is not on the market, and the standard chemotherapy is what you're going to get anyway. So I would encourage us to think about clinical trials, because we will never make progress without clinical trials. This is going to give me 2 minutes of advertisements for your tax dollars that are spent on clinical trials. We are going through a really tough time. I recall that back in the mid-2000s, we had a period of time where there was sequestration. What that meant is that every department in the government had to lose about 20% or so of their funding, whether you were National Park or whether you were National Cancer Institute. A lot of our trials shut down, and some of these trials actually moved outside of the US. And if you look at actually the gynecologic cancer space, we were the leading organization and operation in the world to come up with 50 years of gynecologic cancer trials. They were all done through the Gynecologic Oncology Group. When that sequestration happened, we then had to combine our efforts along with breast cancer patients and head and neck cancer patients and colorectal cancer patients to compete for those dollars. And so we had a lesser access to that piece of pie that's being distributed by the government. And believe it or not, starting about 2005, a lot of those trials moved over to Europe. And so in the recent years, when we look at clinical trials, a lot of that space is filled with European trials. It's not bad, it's just lost opportunity for our US patients. This year, we have had a really, really significant challenge. I received actually an email just this week from American Society of Clinical Oncology highlighting the fact that 40% of the budget dedicated to National Cancer Institute is at risk. When I say at risk is that we know that we are trying to really shave down the spending of the government. And I'm okay with that. There is waste. There is no question there is waste. But National Cancer Institute and National Institute of Health, they are doing work that's benefiting each and every one of us in this call, in this state, and in the United States of America. And when that budget cut goes into effect, laboratories will not do basic science research. Those lack of initial basic science research will translate into less development in the clinical trials and eventually will lead to less available new drugs for cancer, for heart disease, for neuromuscular disease, and across the board. We don't have a lot of options. We are living through tough times. The only thing we can do is to communicate through our representatives and state to them that these are not trivial investments. These are investments that will affect each and every one of our lives. And we need to push to ensure that the expenditure on the clinical trials and cancer, as well as other diseases, remain at least at the same level they are today. I go as part of my other hat that I wear, which I chair the Health Policy Socioeconomic Committee for the Society of Gynecologic Oncology. And I visit Washington, D.C. and our representatives on the Hill twice a year. And I, along with some 50 other gynecologic oncologists from across the country, we try to advocate for expenditure on ovarian cancer and endometrial cancer. Those are our two challenges. Ovarian cancer got a lot of funding over the last 20 years. Thanks to whom? It was done through Department of Defense budget, believe it or not. And Senator McCain was a huge proponent of this expenditure. And he was a real big advocate for us. And that research is what has led to actually the rates of ovarian cancer death coming down over the last decade. So it didn't happen by accident. It was designed. It was because the money was well spent in basic research and clinical trials. And today, what I hear from my representatives when I talk to them is that they are just trying to keep the expenditure where it is, but it's really, really challenging times. So I beg all of you to do what you can where you are, talking to your representatives to ensure that the funding for progress in cancer, specifically gynecologic cancers, continues. And that's really all I'm going to say. And I'm really
Dr. Shahin, could I jump in for a second?
absolutely.
I know I'm grateful for you voicing your concerns, and I feel like we hear so much at Unite for Her because we're in this space. And is it just not the future of clinical trials, but you're also seeing already approved funds actually get retracted or taken away? Has that been an experience that you're seeing in the medical field?
So I have colleagues who actually run basic science experiments at National Cancer Institute. On the paper, they're budgeted to receive certain amount of money. And unfortunately, the funds are frozen, meaning that even though they're dedicated to their lab, to their mission, they're not allowed to actually receive it. Now, as you know, some of these are happening at the congressional level about who they're going to disperse this money to. So your comment is correct. Even though the money has already been dedicated by Congress, we're having some trouble actually accessing it.
Okay.
And I know of colleagues who've gone several weeks without being able to complete their experiments that they do in the lab to really do this basic science research. They're not in the GYN space. They happen to be in pancreatic and lung cancer space. But I believe this experience is shared across scientists in National Cancer Institute and NIH.
Okay, thank you.
And I fear about the consequences of that. All right, I'm going to pause for a second, and I want to see whether there are
questions in the chat.
There. I'm going to start from the back. It says, "Where is Rina-S trials?" The company that creates Rina-S or has Rina-S is Genmab, and the best way to go is actually go to clinicaltrials.gov and search for Rina-S to see locally. I suspect in North Carolina, if you reach out to Atrium Health in Charlotte or UNC or Duke, you may be able to identify institutions that have this. It may be more than that. I don't know that specifically to answer to you more. Another question was, does Rina-S have the same awful eye side effects? Actually, it doesn't. And so the drug doesn't bind to the ocular area. And so one of the other question was, will relacorilant work with Taxol as opposed to Abraxane? It will not, because when we give Taxol, we have to give steroids. So the whole point of using the Abraxane is to avoid the steroids. So it's the same drug delivered without the steroids. That's why we chose, or the company chose, Abraxane as the agent to mix it with. I'm going up the chain here. It says, is there a clinical for BRCA negative, HRD proficient, folate 1 just under 50%, platinum resistant and sensitive? So I think these RENA-S trials may apply to you. There are multiple other ADCs that are also being studied. One of them uses the Claudin 6 receptor. That's being done by Torl, T-O-R-L Therapeutics, and it is through the science of it is done at UCLA. So that may be a trial you may want to explore. Another trial is being done by AstraZeneca, and it uses the B37 receptor. And so I would ask you to locally explore, especially folks who have access to phase 1 trials. Some of these happen to be in those areas. I'm smiling because there's somebody here from Iowa City. For those of who you don't know, I did my fellowship at Iowa City, Iowa. Although I love Iowa, and I happen to spend most of it at University of Iowa hospitals and clinics because that's where I lived pretty much. So it's great to see you here on the group here. Carla is your name. All right. So I'm gonna. Let me see. Is there any other?
You had one more at the end there, Dr. Shahin.
Yep, I'm gonna look.
Long-term side effects of Avastin on the body being studied.
Yeah, so Avastin is a very complex drug in that, the main side effects are high blood pressure, DVT or pulmonary embolism. Obviously, it interferes with tissue healing, so you can't have any elective surgery. But even if you fall, let's say if you're biking and you fall, or you fall from steps and you scrape your knee or your extremity, it's going to take longer for you to heal. So these are some of the real side effects that we see on Avastin. Usually, one of the things that we monitor when patients are getting Avastin is looking at the amount of protein in the urine. So we call that proteinuria. If the amount of protein goes above 3 grams in 24 hours, Avastin has to stop. But usually it doesn't go from 0 to 60 all in once. So usually you see a trend upward while you're getting the drug every 3 weeks. And so if the trend is upward, this proteinuria is not a trivial issue. When your body expels a lot of protein, you're going to end up with edema, and you'll have anasarca and swelling in a lot of your tissues. So hopefully your clinician will recognize the excessive excretion of protein and will actually stop the drug before you get there. This is a side effect that's on the kidneys. There are other side effects which we don't talk about a lot. People feel hoarse, their voice changes, or their eyes and their nose is runny. They have the sniffles all the time. We don't know exactly the mechanism, but this is what I hear in the office when I see the patients, and I recognize that that's what it is. Another rarely discussed side effect of Avastin is diarrhea. Patients who receive it for 24 hours, they have diarrhea, and then it stops. So I think we have to be careful and listen to the patient, hopefully either your doctor, your nurse practitioner, PA, really to these side effects and adjust things. Now, one of the other things that I will say about Avastin, in the US, we are accustomed to using it at 15 milligram per kilogram. In Europe, they use 7.5. And in some of my patients who have had the side effects, I've actually tried the lower dose, and I seem to be able to manage that better. So this is not a commonly practiced intervention, but I will say to you, if you're benefiting from Avastin but are struggling with some of the side effects, lowering the dose but still giving it at the same frequency does help. You had asked, what are the bowel involvement with Avastin? Well, Patients who have tumor right on the major blood vessel or on the bowel probably are not the greatest suitable candidates for Avastin. So Avastin can cause a lot of harm. I recently actually gave it to a patient who had come to me from Delaware. And after receiving the first cycle of chemotherapy, she actually had a bowel perforation. And we had to do an emergent surgery on her, and she ended up with an ileostomy. And, that introduced the whole 6 weeks delay. So it's not a trivial drug, and, we have to always weigh the benefits and risks. In my case, the patient had a lot of pleural effusion, fluid in the lungs, and I was trying to help her, but this happened. So every gynecologic oncologist you talk to, they're going to share with you a story of a Avastin mishap. Um, and usually, um, you know, if we are planning a surgery, I tend to stop the Avastin at least 6 weeks before. And if the patients are post-op, I usually like to make sure they're 6 to 8 weeks away from surgery and they're healed before I introduce Avastin again. Typically, the first cycle of chemo after surgery, I do without Avastin. One of the questions here was, mom was diagnosed with ovarian cancer at age 82. It has metastasized. Doctor says can do surgery due to extensive area, and only option is chemo. So I would basically say start with the chemo and then explore your surgical options. Maybe you want to talk to another clinician who does surgery and see whether is the surgery possible. Certainly, if you reduce the volume of tumor, then you can consider whether surgery is appropriate or not. But I think the decision is really individualized. I have a patient currently who has really bad heart disease. I mean, she's on a lot of medications, and I worry that if I do a surgery on her, I'm gonna lose her to the cardiac complications. So one of my old teachers used to tell me that the shortest life expectancy for a cancer is a postoperative death. So I have to consider that. I have to really make sure that I can take the patient through that surgery. It's not trivial, and it's going to require an effort from the surgeon as well as the cardiac team. In a patient who is 82, sometimes we give a little bit lesser dosage of the chemotherapy and we still do okay, just we don't have to push the limit on the chemotherapy drug. And that's one of the tricks, to get them through the first 3, 4 cycles. And then during that time, you have 12 weeks to get maybe 2, 3 opinions about is surgery suitable for this person. And maybe you just have to find the right person at the right institution with the right resources. You want to make sure you're at a place where they're comfortable rescuing the loved ones or yourself when trouble happens. Every surgery has complications. If a surgeon tells you they don't have complications, that's because they either don't operate or they lie. But the question is, when a complication happens, do we have the team in place to rescue you? Whether it's a wound infection, whether it's a pulmonary embolism or a heart attack or all of those things. So we just have to be careful about that. Anything else you see, Erin, that I should address before I move on to the next topic?
There were a couple other questions, but we can always save them for the end because I know there's some other topics that you wanted to cover, Dr. Shahin, which I think would be of interest to our audience.
The last question that I see says, I was under the impression that Jemperli, which is dostarlimab made by GSK, is only approved for uterine or endometrial cancer. That's correct. So your impression is correct, Jackie. They did study it in ovarian cancer, and that's what I was alluding to, that in ovarian cancer, it showed that the progression-free survival improved, but the overall survival of patients did not improve. Now, FDA has their rules about how they approve a drug. My suspicion is that when they're going to look at that information, they may decide that the drug is not worthwhile for the patients. I feel otherwise. I think if you give a drug to the patient and you keep the cancer away for longer period of time before it returns, I think it's still valuable. As long as the patient is tolerating the drug and the cost of the drug is not prohibitive. But in some ways, the bar is looking at this overall survival. But what I've argued actually with some of my colleagues is that the lifespan of ovarian cancer patients is really improving. And these patients are getting exposed to multiple lines of treatment. It is becoming more and more difficult to do an intervention here and see the prolongation all the way out here, 6, 7, 8, 10 years down the road. So I think sometimes how you set the bar may hurt the development of new drugs. But there are smarter people in the field who are making this decision. And I'm just telling you my own personal view that progression-free survival to me is very important. There was a question about how does one determine hospitals or medical centers that are best at a particular cancer? Well, I think you have to do a little bit of a legwork yourself. You have to see how many GYN cancer specialists do they have? How many GYN cancers do they treat? I mean, US World and News, I think, does rank the hospitals, especially the larger centers. So that's one of the ways you can look into it. I'm not saying it's perfect because I've looked at that list and I have my own criticism of it. But sometimes it may lead you to institutions that are high volume and they do enough of it, and then you can get your care through those centers. But if I would be hesitant, if tomorrow I have stomach cancer and go to a surgeon who does 2 of those cases per year. I just think I want to go to somebody who has a little bit more experience, a little bit more volume through that, not to do unnecessary surgery, but appropriate surgery.
Yeah.
I wanted to talk about 10 minutes about exercise and another 10 minutes about managing one of the things that we cause, which is menopause, and how do we deal with that. And maybe they're actually linked together a little bit. So one of the things that I personally recommend highly to each and every ovarian cancer patients that I treat, even if they were not active before, I say to them, it is an opportunity for you to get active. So let's say I meet a patient who is really debilitated from their ovarian cancer symptoms, and now they have to take 3 or 4 cycles of chemotherapy before they have surgery. I tell them during that time, you could improve your cardiovascular health so that your recovery from surgery is improved. So how do we do that? Think about a marathon. What do people do when they run a marathon? They begin to run. They may run 3 miles. They may run 2 miles. They may run even shorter distances. But I ask them to begin to commit to walking. Very simple. All you need is shoes and maybe a friend, and you go on a walk. And this could be 10 minutes a day, 3 times. 10 minutes becomes 15 minutes, becomes eventually 20 minutes. The ideal scenario is that you want to put in about 150 minutes of that sort of exercise, cardiovascular activity into your week. And then you want to mix it with 2 brief sessions of weights. Doesn't have to be a heavy duty weight, but you just want to have some resistance. The resistance will help build muscle. The muscle will help you then actually do more cardiovascular activity. And you're thinking to yourself, oh my God, with the side effects of chemotherapy, the last thing I want to do is to go out and exercise. Guess what? You're going to have endorphins released in your body that's better than any drug that I can prescribe for you for fatigue. You're going to have improved sleep. And once you sleep, your energy is going to get better. So as hard as it is, even in the day after chemotherapy, I beg you, I ask you to go out and give it a try. Do 10 or 15 minutes in the morning, do 10 or 15 minutes in the afternoon, but do some activity. So reduced fatigue we have the bulk of the data in this topic in breast cancer, which is the other, patients that we serve in Unite for Her. And we know out of that group that regular movement can combat cancer exercise tiredness, improve your strength and flexibility. But I'll tell you, I talk to every patient about this, and I would say less than 30% take me up on it. So I hope I can really push all of you to think about that. So find friends, maybe go to your neighbor and say, can I walk your pet, your dog, whatever. Find an excuse to be out there. You say, well, it's winter, it's Iowa, I can't really do this. Well, guess what? There are malls. Go to a mall and do the walk in the mall in the morning or in the afternoon. Many of you who are over 65 may actually be able to qualify for silver sneakers. So look and see what gyms offer that. You could actually participate in that completely free, no charge, and your Medicare dollars pay for that. So another thing that really helped is yoga. And the minute I say yoga, people have this vision they have to stand on their head. You don't have to do that. Yoga allows you to have 30, 40, 60 minutes where your brain is a little bit shut down and quiet. You're not thinking about cancer, chemo, children, husband, family, sister, mother, all bills, all the things that you're dealing with. And it allows you to shut that brain down, quiet it down, focus on stretching, focusing on increasing your range of movement. And yoga has had documented benefit in reducing your side effects from chemotherapy. So no matter what you're on, yoga can be beneficial to you. And I recommend at least 2 sessions per week. Now, you don't have to join a gym. You don't have to join a yoga class. Nowadays, you can find it on Zoom, YouTube. If you are part of the Peloton, app or something, there are yoga classes on Peloton you can take. But yoga and meditation is a really hard one. I have a extreme difficulty shutting the brain down and really quieting things down. But the benefits are unmistakable, and there is so much literature out there. So, I know it's, people want to know, like, how do I do this? Like, where do I start? I honestly suggest the silver sneakers and some of your local gyms. I want to put a plug in for Live Strong. I don't know whether go to your computer and type in Live Strong Foundation. This is from Lance Armstrong. These programs are offered in many gyms. There and community centers for that matter, and you can actually join them for about 6 months period. They are designed to take the patient who has suffered consequences of cancer and chemotherapy and kind of rescue them and bring them back to a normal level of activity and endurance. So that may be something you, and it's coached. So they talk about diet, they talk about exercise, they literally sit you on the machines and teach you like how to use it. So I think the benefit is you get exercise, you get socialization, and you get coaching. And these are not, they're not done by just anybody. So I think that's really good. Many of the local YMCA offer this. I think that just came in one of the texts I'm looking over here. Rhonda tells me she's a graduate of Livestrong, and she attests to that. So it's an awesome program. So I want to really put a plug in that. Anything else you want to add, Erin, about exercise?
No, you're getting, well, we did have one question. Leslie was asking, like, if there's a particular kind of yoga. I know, because we hear these different words of, vinyasa, and if it needs to get that specific. But I think what you've shared is just, it doesn't have to be the stand on your head type.
Gentle yoga or yin. YIN, yin yoga. Those are sometimes the best to start with. If you feel particular strength and you really don't feel like let's say you think this is just too easy, there are variations of yoga classes that really will, bump up the cardiovascular system. So there are yoga classes where people actually use weight and do some of the exercises, but that's not, I'm not telling you that's where you start. You start with gentle yoga and yin yoga. Those are the best to start with. If you feel comfortable with it and you feel like excelled in that range of motion and the poses, then you can start trying on more challenging classes.
I can add in here too. This is what Unite for Her does, right? So I put a couple of different links in the chat. You'll see we've had a lot of recorded professional advisors doing sessions of yoga. Start there. You start at any one of those classes. It will allow you to get a feel of what your level is and what you feel is going to be good movement with breath. Always start slow. You always want to start slow. I remember just doing 5-10 minutes and it was a game changer, just those 5-10 minutes. And then the next thing you're doing 15, then 20. And then for those that have an active passport, remember we do one-on-one private sessions. So you can use your passport for a one-on-one private session with our advisors, our professional team. And they'll do it like this, like we're talking to Dr. Shahin right now. And you can be in the safety of your home and actually work through a session of yoga, and they'll tailor it right for your needs, which is great, right? When people are coming to yoga, some have a lot of energy and are really high energy, and they have to start moving. Our professionals will start them with walking around in circles, maybe because they just can't quiet their mind. And then others come to us and they are so lethargic that they got to start on the ground and they got to sit and just move slowly to get to a level of energy. We want to be in the middle, that balance. And that's what yoga does. It brings you either down or up to give you balance. And that movement and breath quiets the mind. That's another thing that yoga can do, where you have so much negative chatter in your mind, you just don't know what to do with it. Those types of movements with breaths, counting, meditation helps with that negative chatter. So please start on our library. Erin put it there. I put a lot of direct links. I was just looking them up so you could find them easily, but they're all in the chat. And Dr. Shaheen, we can't say enough about exercise and movement, and it doesn't have to be crazy. It walk, just.
And I really encourage you to try things that you haven't tried. So let's say you excel at your walking, take a cycling class, but let's say if it's a 45-minute class, say I'm going to do 15 minutes of it and see how I feel. And that's enough. And a lot of times, if you're going into such classes, go to the instructor ahead of time and say, I'm not being rude. I don't have the stamina to do a 45-minute class, but I'm going to try 15. Trust me when I say that most of the instructors welcome those individuals. Their goal is to really individualize that for you to benefit. So walking, yoga, tai chi, light aerobics, all of these things are good. Remember what I said, 150 minutes should be for moderate intensity, and maybe 2 additional sessions of weight bearing exercises. Even if it's lightweight, it doesn't have to be super heavy. And those can be typically coached. Many of those programs that we just touched on offer those things. There is a question about HIPEC and HIPEC is basically heated intraperitoneal chemotherapy. So one of the interventions that's been proven to be beneficial is actually intraperitoneal chemotherapy, but it was very difficult, cumbersome. I still like it, but for many of our patients who receive interval debulking surgery, if they are in good shape and they don't have a lot of medical issues, especially with respect to their kidney function, heated intraperitoneal chemotherapy can be a good solution to essentially try to sterilize the abdominal cavity. But again, there is lots of inclusion-exclusion criteria. So if you have a stage 4 disease with pleural effusion, HIPEC is not going to help you. If you have a stage 1 or 2 disease, HIPEC is not going to help you. If the surgeon cannot completely visibly remove all the disease, HIPEC cannot help you. So it's for select patients. It takes a little bit of orchestration, and it adds about 2 hours under anesthesia. And typically patients end up a couple nights in the intensive care unit with really close monitoring of their fluids, their kidney function. I think in the right setting, it can improve overall survival by 9 to 12 months. But it's not for everyone. So I don't want for you to leave here thinking HIPEC for all, so there is no such a thing. In the remaining time, I wanted to talk about menopause. Unfortunately, with the treatment of ovarian cancer and many gynecologic cancers, we are unable to spare the function of ovaries. And ovaries are one of the most complex organs in our body. They produce estrogen, they produce progesterone, they produce also testosterone. Many of you may be surprised to hear about testosterone, but testosterone is produced by ovaries as well as your adrenal glands. When testosterone production shuts down, your desire to have sex, libido, is reduced. And this is a huge problem, and many of the docs and patients don't even talk about it. The first thing that comes about following, surgical menopause, when you're forced into this, is that you notice that obviously there are vasomotor symptoms, otherwise known as hot flashes. For some people, they describe them as hot flashes. For some people come to me and they say, I feel shivering during the day, lasts about 30 minutes, 60 minutes, 60 seconds. These are all vasomotor symptoms because the circulating estrogen level just dropped. And it's very unpleasant, especially if you're outside or if you're inside, and it can create challenges if you have a partner at home. Then it begins to disrupt sleep. So what did we talk about? Disrupted sleep leads to, we know today, by the way, sleep is extremely important. So we talked about benefits of exercise, but benefits of sleep. 6 to 8 hours is sort of the norm nowadays. And if you're not getting sleep, your immune system is reduced and your longevity is reduced, regardless of whatever else you do. So sleep is extremely important. And when your sleep is disrupted because of hot flashes, there is issues with that. Now, probably the biggest damage we did in healthcare for women was back in 2001. The results of a trial came out called WHI study, where we looked retrospectively at cohort of women who were on estrogen and progesterone or estrogen alone. And we looked at that and we said, oh, there is increased risk of breast cancer, there is increased risk of cardiovascular disease, stroke, and everybody stopped. Everybody stopped prescribing. And the reason was back in the 80s, we thought estrogen was really the key to all benefits. And so many women who were not on estrogen, they were 60, 70, they were actually put on estrogen. And we didn't really know all the details. I can tell you some 20 some years later, when we look back at that study, the detriments of estrogen was really not as bad as advertised. So in a cohort of population of 10,000, there might have been one extra case of breast cancer. And the question is that random or is it chance or is it really a cause by estrogen? So I think it got a bad rep. And also the formulations for estrogen has changed. So many of the docs today, even OBGYNs, they're uncomfortable practicing and actually prescribing. We are having a new generation of physicians who are really dedicating themselves to menopause medicine. There is actually a dedicated society to this and identifying people who are really appropriate candidates for giving estrogen to. Now, I'm not going to sit here and say estrogen is appropriate for every patient, but around the time of surgery, estrogen will increase risk of blood clots and pulmonary embolism. So it may be appropriate to come off the estrogen if you're having surgery or immediately post-op. But there may be a time where your physician can put you back on that. I find that prescribing it transdermally through a patch maybe one of the best ways to get the estrogen back into the circulating system. It doesn't go through the liver, it goes directly into the bloodstream. And we don't have variations in the levels. If you're taking a pill, the level goes up, and then by the next morning, the level falls down. Whereas if you're taking a patch, typically it's very steady. The patches are prescribed typically twice a week. Most patients with ovarian cancer are potentially candidates to receive estrogen if they want to for these benefits. There are particular types of ovarian cancer called low-grade serous carcinoma, for which I don't recommend it. There is also another disease that we treat, which is a low-grade stromal sarcoma of the uterus. Those patients are probably not good candidates for estrogen therapy because the estrogen may actually stimulate their tumor. But for the bulk of the patients, if they have menopausal symptoms, they probably can receive estrogen as long as there is no contraindications. If the blood pressure is okay, if there is no history of blood clots, they would be appropriate. But suppose taking a patch or a pill is not for you. The estrogen can be delivered also transvaginally. So we could use a cream or a tablet that can be placed in the vagina 2-3 times a week. Some of these delivery systems are actually once a week, and it will relieve vaginal dryness and burning. It will improve sexual intercourse if you desire to remain active, and I encourage you to remain active if it's possible for you. And the other benefit that I really see that I think estrogen is underutilized for is actually reduced frequency of urinary tract infection. So one of the things that we see in our patient population is that they have frequent urinary tract infections. And so when the estrogen is diminished, the tissue around the urethra where you urinate from becomes atrophic. And it actually does not have local defenses against bacteria. And so the bacteria can get into the bladder faster. So one of the most common reasons I actually talk to a patient and say, hey, we should talk about some vaginal estrogen cream is actually increased rates of urinary tract infection. Now, what happens in urinary tract infection, especially when you're older? You end up in the hospital with typically sepsis and pyelonephritis or kidney infection. So it does have consequences on the system. So if we can reduce bladder infection, we'll reduce some of those urinary tract related sepsis as well. So I do want to put it out there. Actually, today I was talking to a patient and she kind of told me, no, it causes cancer. And I said, show me the evidence and don't show me the black box warning on it because that's from that WHI study that didn't even have estrogen vaginal cream studied anyway. But it's something that I wanted to share and make sure the community knows about it. It's available. I really think it's like if you're an ovarian cancer patient and you're seeing your GYN oncologist, this may be a visit. Maybe you just want to dedicate a visit to talk about your sexual health, your menopause, things like that, unrelated to your cancer, and if your provider is not comfortable with it, then find somebody in your area that does menopause medicine, and you can maybe bring the topic up in a comfortable setting. It's funny, I also saw a patient this afternoon, and she wanted to. This is a uterine cancer patient from 6 years ago, and she actually sees her gynecologist too, who's a woman actually, and she says, today I want to talk about sex. I said, okay, let's talk about sex. And she then opened up and she says, I haven't talked to my female gynecologist. I said, that's fine. It's not a problem. But today's visit was basically on the topic of burning sensation, dryness, difficulty with intercourse, and how we can improve on those things. So I think you owe it to yourself. If that's an issue and quality of life is an issue, you should find providers who really can talk to you comfortably about this. and go through pros and cons of, what strategy is best for you. So I think it's an important topic. I'm going to pause for a second and just go to questions. Aaron, maybe you can help me if there is anything. Because should one avoid estrogen like in dairy if one's tumor is estrogen positive? So that's a great question, Jane. And many, almost all ovarian cancers are going to be ER positive or estrogen receptor positive. And if you give those patients an anti-estrogen, it doesn't treat their cancer. So just having the estrogen receptor doesn't mean that it's estrogen sensitive. So I would tell you that I'm not sure whether you need to avoid the estrogen. I'm not a big fan of dairy, by the way, if you didn't know that. I tend to stay away from dairy. I encourage my patients to stay away from dairy. There's plenty of alternatives to milk, such as almond milk, soy milk, oat milk that you can consume. And I would encourage you to do that. They have done studies specifically in breast cancer, so estrogen receptor positive breast cancer, where consumption of soy does not increase risk of breast cancer recurrence. So somebody just asked, Heidi says, is soy bad? Absolutely not. Soy is a phytoestrogen and tends to actually be beneficial for breast cancer and does not have those things. And it is true for ovarian cancer as well. So I would say that's my opinion on that. There was a question about, is it safe to use intramucosal or topical estradiol? Has it been studied in ovarian cancer? I can tell you that there hasn't been a dedicated study done in ovarian cancer, but I can tell you both of those agents are safe in ovarian cancer based on clinical experience. And I'm just going to leave it at that. The largest study of topical, meaning like vaginal estrogen, was done actually in breast cancer patients and showed no difference in recurrence. And so to me, that's actually a pretty solid study, and I'm happy to share that with you. I'm going back. Should I go back to my breast oncologist and revisit the topic, as she was adamant to utilize any estrogen? Sherry, my feeling is that a medical oncologist treating breast cancer is always going to tell you that's going to be their standard answer, that you should not use any estrogen. I don't know your particular case well, but I would encourage you to maybe speak to a menopause medicine individual. There is Every case is complicated. I don't know what your breast cancer was, but I think vaginal estrogen cream is safe, and you probably could utilize it unless there is a particular issue that I don't know. There was a question, is estrogen cream also for full hysterectomy patients? Hysterectomy just means to me that you had removal of uterus and cervix, but I think you mean oophorectomy when you say full hysterectomy. And I would say, yes, you could use estrogen cream following removal of the uterus. I typically wait about 2 months or so to ensure that the top of the vagina is healed, and then I can introduce the estrogen cream in there. There's a comment about pelvic floor physical therapists recommending hyaluronic acid and suppositories instead of estrogen. I don't have anything against hyaluronic acid. It exists in your joints and some of your body spaces. I'm not sure whether we've ever looked at estrogen versus hyaluronic acid. It is a lubricant. The benefits that I talked about with respect to recurrent urinary tract infection will not be observed if you use hyaluronic acid. It may improve lubrication, but you may not get some of the other benefits of vaginal estrogen cream. Have I tried acupuncture to treat hot flashes? I think Sue used that as an answer. Great modality. I think it's underutilized. There's not a lot of knowledge about acupuncture providers in the area, and so I think if you feel that's an appropriate treatment for you, you should do it. The issue is that you're going to have an ongoing acupuncture relationship, and if that's acceptable for you and it works for you, it's good. There was a question: can you share the rationale for removing dairy since calcium is so important? Well, I think calcium can be derived from eating fruits, leafy green vegetables. I'll let Erin maybe comment about that. Dairy has been touted by dairy industry to be a great source of calcium. But that's because they are selling you dairy and they need to sell that milk to you. I'm going to make an analogy, which is really weird, and I just want you to bear with me listening to this. And I've often said, name me one other animal on the planet who drinks another animal's milk. There isn't. We are the only species who are doing this. And I was never a fan of it, but my mom fed it to me like crazy. And many of us have developed lactate-related issues, which messes around with our GI system. Milk has growth hormones in it. The reason milk is produced by the cow is to allow the calf to grow into a cow in less than a year. Those growth hormones have been shown in a laboratory setting to also cause growth of cancer cells. While I cannot prove to you that drinking dairy or utilizing dairy is going to worsen ovarian cancer, those type of laboratory experiments results worry me. So I'm just telling you, I'm not a fan of dairy in our cancer patients. Erin, you want to chime in with your calcium recommendations?
Well, I was going to say also, let's not forget plant milks are all fortified with our bone building nutrients, as well as, we can get them from a variety of our vegetables and fruits and our plant foods as well. Plus, I often coincide this conversation with the importance of weight bearing exercises when we're thinking about supporting our bone density as well. So while nutritionally, things like calcium, vitamin D, vitamin K, magnesium are really important, more so, if not at even level, those weight bearing exercises, the impact they have on supporting bone density is just as important of a conversation. So you can absolutely find nutritional calcium from so many different plant sources as well. And fortification is a great way to get them. So I will concur.
Erin, I popped in the chat our nutrition hub because all of these different tips and ideas and just, guides to how to get the best plant protein, your calcium, so you can look right at a glance at our guides right on our nutrition page, as well as cooking along with our dietitian team, which all of you have access to. And you all have access to be on a cooking demo with Erin and Catherine and Aubrey. So know that we are here to answer all these questions, nutrition, all things nutrition, which is such a big topic for the majority of our community for sure.
Yeah. And I do want to call out Jane's comment. She stopped dairy periodically. She has some cheese and other things. And I think, also our approach to nutrition is not necessarily an all or nothing. So even if pulling back on cow's milk and cow's milk products is something that you want to strive for most of the time, if you want to have that cheese or incorporate some yogurt, you can have this flexitarian approach almost to nutrition and food. So you don't necessarily have to be all or nothing. And that is why nutrition can so beautifully be individualized.
Yeah, we always talk about our dairy as a condiment. Think of it, our dairy as a condiment, not your whole dinner. The cheese plate should not be your whole dinner. Think of it as a condiment, just a little bit, right? If you want to put that in. But Erin can give you so many other swap outs, which is what we are so known for at Unite for Her, is our nutrition program.
Yep.
Thank you,
There's
Erin.
a question about whether estrogen replacement is appropriate for a BRCA1 patient, and that's a complicated question. So obviously, many of our BRCA1 patients choose to eventually undergo risk-reducing surgery. They may have their ovaries removed, uterus removed for prophylaxis, often by age 40 or so. And then they also undergo mastectomy. Um, I think in the patients who have had the oophorectomy and mastectomy, I have absolutely no problem putting those patients on estrogen. And on the patients who've had the oophorectomy and hysterectomy done, they can be on estrogen as long as they are, if the breast is intact, they need to ensure that they are. Well, actually, I'll go back. The BRCA patient's breast cancer typically is the triple negative breast cancer. That's the most common cancer that develops in them. So they're not even estrogen related. So I think you need to discuss this with the surgeons and the medical oncologists who are involved with you. But it is an option for you to utilize estrogen. So it's personalized medicine. Those were the topics that I wanted to really review with you. I'm happy to delve more. Let me see. There is one question. I had to go on letrozole due to liver issues on my last treatment. Now you're on letrozole only because your tumor is estrogen driven, and it's taken me back to no evidence of disease. And now you are without disease 10 months. Is this common? Why isn't it used more? Side effects are minimal compared to chemotherapy. Well, Melanie, I can tell you that letrozole has its own side effects. Many patients complain of vaginal dryness. They complain of joint pain. So it's not without side effects. If that's really working with you, it is wonderful. I'm really glad that this is occurring in you. Obviously, for you, and I don't know your specific type of disease, it sounds like estrogen is probably not appropriate because you're actually utilizing an anti-estrogen approach to achieve no evidence of disease. So I would encourage you to speak with your oncologist specifically. But even on patients with letrozole, if they have vaginal dryness and recurrent urinary tract infection, you probably could use vaginal estrogen cream because the absorption systemically is so minimal and low. So
Dr. Shahin, there's been so much chatter about vaginal estrogen cream because I know even like GYNs are now seeing the data and the studies are that they're safe and that they can use them. But there are other products like Good Clean Love that's out there if you are nervous about the estrogen, that you could use that as a vaginal moisturizer, just like we moisturize our skin every day. It's important to moisturize that vaginal wall. We don't think to do that. And if we start that as a habit in our younger years, not when we're going through menopause, it's actually very beneficial. So I think talking to your doctor and your GYN about your particular case, as well as this, need for an estrogen that's a vaginal, topical solution. Have you heard more and more women using this now, Dr. Shaheen?
yeah, as I said, I think we did a disservice to women some 25 years ago with the
Yeah,
release
with
of
that study.
there was silence for a while. People were really hesitant. But I think there were pioneers in the fields who kind of re-educated us about the benefits of it. And I do see more utilization of it. And listen, estrogen vaginal cream is just the beginning. There are some women who need testosterone supplementations. This field has become a little bit of its own unique field, and I think we need to be aware of the fact that um, ultimately the goal is to restore healthy life and good quality of life. So if you are suffering from vaginal dryness and so forth, it's appropriate to intervene. There is a question that says, I'm not experiencing vaginal dryness even a year after surgery. Should I start a vaginal estrogen cream to prevent some of these issues? I don't know what your circulating hormones are. I don't know whether your ovary is intact or not. But I do think it's a conversation that you should have with your provider. At age 39, I'm thinking if you're menopausal, um, there are going to be consequences on your bone density. What are you doing yet? How are you addressing that? Is estrogen the right answer for you there or not? Vaginal estrogen is not going to address that. Maybe you're more suitable for actually a systemic replacement. Are we observing and looking at your DEXA bone density exams frequently enough to assess which direction things are going? And also, if you happen to have removed your ovaries at age 39, you're at a higher risk from a cardiovascular disease. So we want to make sure you're not a smoker. We want to make sure your cholesterol profile is absolutely perfect. We want to make sure you have access to cardiologists, that you have been able to establish a relationship. So if there is a risk factor, they can address it. Because one of the significant adverse effects of early menopause is a higher risk of cardiovascular disease when you're in your 50s and 60s. So yes, you might have reduced your risk of ovarian cancer, but we want to make sure you're protected against other conditions that could shorten your life expectancy.
Well, Dr. Shahin, amazing. Yeah, I think we could go on all night. We
Good.
could.
I'm glad I was able to address the questions. This is exactly the kind of forum I wanted. I
Yeah.
mentioned to Sue and Aaron, I said I want to make sure that what I say addresses the concern of the audience, and I feel like we've sort of accomplished that. And I'm sorry if I didn't get to answer some of the questions. So it's been an honor being in front of you tonight.
Well, thank you. And we will put, I'll actually put my email in the chat. If we did not get to your questions, we are directly connected with Dr. Shahin, and we could actually send you an email to get those answered, because we don't want any to go unanswered, right? So wonderful. Thank you, Dr. Shahin. It was so thoughtful. I'm always learning. Aaron, we are always learning. And it keeps, progress keeps moving. And sometimes progress can feel small, but that sets us up for the next line of treatment, right, Dr. Shahin? So it's always important for us to understand how important clinical trials are, and to ask your physicians about them. Are they right for you, right? Are they right for you? And are you a good candidate? So we appreciate you pioneering that space. I know you do a lot of it. And I'm always in awe when I get to listen to all the knowledge that you have. So thank you.
Thank you. Thank you for
Yeah.
your comments.
Yeah. All right, Aaron, I think that's a wrap.
Oh my gosh, I think we'll all be going back and watching that recording tomorrow, because there was a lot that we covered, but this was amazing and nothing short than what we expected.
I know. We went all the way through. I thought for sure we were going to go into nutrition now. And I'm like, oh, the topic. Here we go. And we have the woman for you right here. However, she has done many. So look at the chat. I have put so much information in that chat for you on nutrition, and join our cooking webinars. You get to talk to Erin live doing a cooking webinar in her kitchen 4 times a month. Like we have our
I have one on Saturday. Shameless plug, cooking class Saturday morning.
Like, how many people have access to registered dietitians anytime? Unite for Her friends do. Unite for Her friends. So, Erin, another great topic. Thank you so much. And Dr. Shahin, we really appreciate your time tonight and staying on. I know we went over, but it's really important
worth it.
to address a lot of the questions. So again, we would love to thank our sponsors. We can't do what we do without them. They are continuing to grow for Unite for Her, which is so important for us to continue to have these experts on. Our presenting sponsors are West, Merck, Lilly, Gilead, and Novartis, with gold sponsors from GSK, Pfizer, Daiichi Sankyo, and supporting sponsors from TerraSera, AbbVie, and new Veristim. So thank you for joining us and allowing us to go from having, boy, Aaron, when we first started, we had 12, and then 24, and then 36, and now 41. And now I feel like we're pushing the 50s.
We are. We have 5 this month. So yes, we are definitely going over. So, and I will quick tease all of you again. We've got a lot happening next week. So Wednesday the 10th, 5 p.m. Voices in Oncofertility. We've got a panel with a oncofertility specialist out of MD Anderson. Worth the Wait will be their a nonprofit partner, and we'll have a patient representation as well. And then Thursday, we've got two things happening. So 1 p.m. Eastern time, we'll be streaming live to our Facebook page. Aubrey and I will be diving in with a fellow dietitian and expert in supplements and cancer, Natalie Ledesmy, asking all of your questions, or as many as we can get through in our time about supplements and cancer. And then that evening, you heard Dr. Shahin talking about heart health. We will be learning about cardiorespiratory fitness and cancer from, again, another expert in the space, physical therapist expert from our local area. So that is at 6 p.m. Eastern time, and all will be recorded, and we will just keep building out that video library. So if you can't join us, know it will be available to you.
I love the video library, Erin. As all the, community were chatting, I'm like, oh, we did something on that. Let me put it in the chat. Oh, we did
everything.
Let me search it, and just like that comes up, and we put it in the chat. So please get on our library. There's such a wealth of information, especially in a time where facts are tough, right? To find what really is true and good for you and meaningful, and that's where we come in. And we have very trusted professionals that can lead you down the right path. And of course, you and I, we're always available. You have our
always.
emails, always.
Yep.
All right. Well, that's a wrap. I think you have an Eagles game to get to, Erin.
Yes, we do. I know. Go Birds. But thank you for spending your evening with us. This was wonderful. Thank you for all the engagement and questions. And hopefully we will continue to see all of you at future education segments. So enjoy the rest of your evening, everyone.
Yeah. Thank you for spending the evening with us.
Thank you.
Everybody.
Good night.